Hi everybody, I want to thank the people of Botis for the opportunity to share with you my observations on socket preservation in the posterior jaw. Socket preservation is a procedure usually targeted to the aesthetic zone, but there is a growing attention towards the posterior area. And the question is, should we always preserve the posterior socket? But first of all, let's define socket preservation. In my view, Vinoletti had defined it very accurately. Any therapeutic approach carried out immediately after tooth extraction aimed to preserve the alveolar socket architecture and to provide the maximum bone availability for implant placement. In other words, anything you can do in order to not get this kind of resorption. And we do get such results from time to time. In the literature, it is quite accepted that internal socket grafting minimizes ridge collapse. And there is a variety of filling or grafting materials that we clinicians can use. But to enhance the healing, we probably need to seal the socket. And for sealing, we may use all kinds of sealing materials and sealing techniques. So also here we have multiple combinations like allogenic bone with PRF membrane or autogenous bone with commercial membrane or growth factors with just flaps, or alloplast with soft tissue graft, like in socket seal surgery that we actually implement only in the anterior zone. In the posterior zone, the soft tissue graft doesn't survive. So the variety of materials is immense, and every clinician probably has his own recipe or approach. The reason we graft the socket is mainly to help in stabilizing the clot. And the reason for sealing is to protect the clot. A protected clot is the key for successful regeneration and minimal resorption. And by successful regeneration, I mean achieving high bone quality, high bone volume, and normal physiological topography. So before I demonstrate the variety of preservation procedures, I have to pose this question. Do we always need to graft and seal the socket? And the answer is, of course, no. I want to emphasize that sometimes you really don't need to preserve the socket because the socket walls may be so perfectly intact, with great potential for spontaneous regeneration. For example, here. It's a good type 1 socket, meaning it's got bony walls, relatively thick and solid. The bony septum is high. In fact, perfect conditions for clot stability. And at 6 months, we managed to end up with a wide ridge with only a slight resorption of the buccal wall. And look at the quality of bone. It's a native bone, and a native bone is without any doubt the best. Here we can guarantee bone quality. And with simple flap manipulation, we can end up with also an aesthetic result. But not all cases have such friendly conditions. Here's a socket type 2, where we have lost few millimeters of the buccal plate, and we filled up the socket with Max Graft. This is my favorite bone substitute at the moment, and I felt it would be safer for the bone graft to protect it with a collagen fleece. Yes, the fleece disintegrates within 2 to 3 days, but in the meantime, it keeps the particles from spreading out of the socket And the fleece also allows safe, uninterrupted initial steps of wound healing. And this, of course, is critical to the overall result. What we see here, also in this scheme, is probably a superficial layer of particles embedded in fibrin. And this superficial layer eventually either integrates with the regenerating bone or stays incorporated in the flaps. And some of the particles might actually pop out from the wound and voyage onward to the stomach. Anyway, it may not be that critical. And if you watch the case at 6 months, as we expose the ridge, we take a sharp periostal elevator. It's a Pritchard number 3, and we start looking for the loose particles. We scrape the surface over and over again, and we found here only a very thin layer of disintegrated particles. And once we reach a hard solid surface, we start the drilling, and here we are already placing the implant. The quality of the drilled bone was kind of type 2 all the way. The implant is even stuck in the osteotomy, so I had to reverse the implant and take another drill just to oversize the osteotomy. And now I can safely insert the implant all the way. And the insertion torque I used here for sure exceeded 35 Newton centimeter. And this, of course, is suitable for one-stage implant placement. And of course, we can lean the buccal flap on the healing cap to get the desired tissue profiles. And here another example, case number 3. So here we placed the allograft and sealed it this time with Mucoderm. It is a xenogenic soft tissue substitute, and that had protected the wound for only a few days. And at 1 week, it's gone, or we see just remnants of it and fibrin formation. Over the following weeks, we can expect to see some particle loss. And at 4 weeks, we typically see soft tissue creeping in between the particles and some particles popping out. It seems that both the Mucoderm and fleece serve as good sealers, but actually only during the first few days. This should be enough for the vast majority of particles to stay in the wound and consolidate. So bone volume is okay, but I still have good reason to suspect that the quality of the superficial layer of the regenerated bone in the socket is inferior to the bone regenerated in more apical layers. But don't we want the superficial layer to be of the highest quality? So in each and every case, I scrape the crestal bone, meaning I remove non-integrated particles till I reach a solid, supposedly real bony surface. Anyway, here's the case upon crown connection. And here, 1 year later, look at the crestal bone around the implant, which solidified even more. So to maintain as many of the particles as possible inside the socket and to improve the quality of regenerated bone, even within the most superficial layers, it might be better to seal the socket not just for a few days or a week, but also to isolate better the soft tissues from invading the wound. We can do this with a membrane that is placed under the flaps. Remember, we are talking today about the open healing approach. So if we keep the resorbable membrane exposed, it will resorb too early. So I would recommend placing a PRF membrane and perhaps 2 layers of PRF just to prevent quick resorption. This may also enhance flap closure over the membrane. Let's view a case. In this case, case number 4, the buccal bone is partially missing. Here is the allogenic graft, the membrane, the PRF membrane, sutures, and almost complete tissue closure at 3 weeks, and definitely at 6 months. And the ridge is ready for implant placement. Here again, after scraping out the loose particles, and there are not too many of those, we prepare the osteotomy in a type 2 bone. And again, we use the full series of drills. You can feel the hardness of the bone, and we see that the implant is indeed inserted in a dense bone. And definitely I'm using here a relatively high torque to insert the implant with a handpiece. And I can add that typically, in order to insert the implant to the right position, we usually need the ratchet as well. So we continue with the case, and again a single step implant placement with the buccal flap leaning on the healing cap and getting a nice tissue housing around the crown. And another typical case with bone allograft and JSON membrane and PRF membrane. This time 2 implants are placed at 6 months, again in one stage. And the final result. And another case, here the palatal bone is partially missing. We place the JSON palatally to rebuild the bony wall. We bend the membrane on top of the bone graft and the PRF membrane to cover the JSON. So the membrane probably stays intact or almost intact for a couple of weeks or even more. And this again seems to be enough to regenerate the palatal wall, and we get a wide ridge with high bone quality. And again, upon ridge exposure, we find only few wandering particles. We don't have many tissue tags to remove. So really most of the bone graft had stayed in the socket and solidified. The bone is quite dense. We can fill it with drills. We widened the osteotomy drill by drill. And finally, we definitely placed the implant in a high torque with the handpiece. And also manually. And again, the implant is placed without the need to bury it under the flaps. And the final result. Anyway, the fact is that no matter what material we've used to seal the socket, the wounds healed with secondary intention. This means that the most coronal layer of regenerating bone may not have the qualities of the deeper layers, as I mentioned before. Well, I have good reasons to believe that we could prevent this by implementing the principles of GBR all the way. This means that by using advanced flap manipulations and special suturing techniques, we may fully cover the membrane by the flaps for a full period, about 6 months. This will allow best conditions for best quality of the regenerating bone. So let's divert for a second from open healing approach and see a classical GBR case. This case was done 21 years ago. We raised the flaps and extracted the tooth without using filler in the socket. We then placed the membrane and fully covered it by advancing the buccal flap quite a distance. Using mattress sutures, we made sure the tissue covers the wound. Not just during the first week, but for the entire 6 months to follow. And indeed here we actually achieved full coverage. Notice it did not prevent some horizontal bone resorption, but the quality of bone was superb. This result was quite good. We managed to shift the flap back to buccal position to compensate for the minimal horizontal bone resorption and get the desired tissue profiles. And here we are already 17 years later. Anyway, this classical GBR procedure is definitely difficult to perform and actually fails in too many cases because of the initial big gap between the flaps and the poor quality of the tissue margins. So it would save us a lot of time, effort, and aggravation if we had a membrane that does not need full tissue coverage and that will not get contaminated, or more important, will not let bacterial invasion to the wound and will not disintegrate for at least 2 or 4 weeks. Indeed, over the last 2 years or so, such a membrane has been available. And you are all familiar by now with the PermaMem, which is made of PTFE. And contrary to the expanded PTFE, it's got a dense structure. And according to the manufacturers, the membrane is non-resorbable, and completely synthetic. It's ultra thin, about 80 microns. Most importantly, it is impervious to bacteria, and it makes our life easier because we don't need to completely cover it by the tissues. Anyway, this year some case studies and case reports started to emerge with indeed very good results related to open healing preservation procedures with the PermaMem. Here's the first case I implemented PermaMem. In my clinic we call it PERMA, or the blue membrane, or just the blue. For this first attempt I chose a type 1 socket. I placed the blue under the flaps on top of the grafted socket, and here the flaps came close to each other but not completely closed. And at 2 weeks the flaps typically recede and the blue is definitely exposed, but it remains rather surprisingly very clean. Here's the membrane again at 4 weeks. We found it very clean, no plaque, no calculus, no debris. At this stage the flaps can be deflected a few millimeters, both buccally and lingually. And now to remove the membrane, if it was well placed under the flaps, you can see that it's rather impossible to do with tissue tweezers. I found it much easier to make a small cut with a blade and then easily retract the blue with the Explorer or a probe. It is clear that the blue protects the particles well, and for a few weeks it acts as an effective tissue barrier. So here the fibrin immediately seen after membrane removal, and the fibrin is maturing, and at 2 months there is almost complete maturation of the covering soft tissue. And at 7 months, when I placed the implant, I found dense bone, kind of type 2 bone of high quality and quantity. And placed here a tissue level implant in 1 stage. And here it is with the temporary crown and the final crown, and mesially to the crown. These are 40 years old crowns with no caries, so we agreed not to touch those. And this 75-year-old guy. Here's another case where we use the allogenic bone and PERMA distally of the existing 2 implants. We see at 9 months nice bone density and addition of a 3rd implant. In this case, case 11, I actually wanted to save the tooth, but its overall condition was very unfavorable. There was massive abrasion of the buccal roots beyond the trunk, and the furcation was extremely narrow. So I removed the tooth. Look at the resorption of the buccal bone on both the buccal roots. I placed the bone and the PERMA. But look at the situation. Since the buccal bone is usually partially missing, and since the membrane is flexible, it will collapse a little. Look again. it will probably not be able to fully maintain the buccal dimension, so we probably won't regenerate the original width of the ridge. One other problem is that because of the existing tissue recession, the flap might be too short, and the membrane will tend to move out too early from under the flap. So I suggest to place the blue more deeply under the flaps, which I didn't do in this case, and oops, indeed the blue disappeared prematurely before the end of first week. Are we in trouble? Well, not really, because the initial protection by the blue, even if it was for just a few days, it allowed the formation of a fibrin layer which is acting physically like a glue between the particles. It's not ideal, but it's better to have wound protection even for a few days than no protection at all. And here at 5 weeks, we got only few wandering particles embedded in the soft tissue that would definitely help their deportation from the wound. Anyway, we got the area fully covered by keratinized tissue after 2 months, and certainly a fully mature ridge after 7 months. And the implant was placed, and you can see the concave buccal plate. Yes, we could probably get a better result for if the membrane could stay a longer time. And the final result, definitely we want better buccal prominence of the ridge, but it does not make a significant impact on osseointegration or on the aesthetic outcome. And another case with allograft and permamem. There was a grade 3 furcation of the molar and a fracture with extensive bony defect of the premolar with a lingual abscess. And here, because of the missing bone, mainly buccal bone, there was a possibility to approximate the buccal flap to be almost in full contact with the lingual. But with perma, once you remove the sutures, the flaps start receding, and this is here already 1 week after suture removal. And the membrane can recede sometimes quite a distance. This time I kept the membrane 6 weeks, but it started to collect dirt. I removed it, and you can see the advanced maturation of the organizing connective tissue with just a little superficial infection, which I didn't treat, I just let it heal. And here at 10 weeks, you can differentiate between the flaps and the regenerated connective tissue. There is still minor deflection of the flap, 1 or 2 millimeters. So after 6 weeks, we typically see the tissue is fully keratinized with some folds. If you prefer, you can smoothen the folds with a scalpel. A laser beam can also do the job nicely and see the bone. Anyway, upon ridge exposure, it is obvious we didn't get the ultimate ridge width, but the quality of bone is very good, and we feel quite safe with the placement of these 2 implants. And the sutures around the healing, caps and temporary crowns, and we finalize the case. And again, this is another case, of course, case 13. No matter how gently I removed the decayed roots, I almost routinely find the buccal bone is missing. That is on the mesial root usually. Again, allogenic bone is routine for me in these cases, and now the blue is becoming routine too. And you can see the typical flap recession at 2 weeks and the typical continuing recession at 1 month. And I think 1 month is the right time to remove the blue. The membrane is probably not necessary anymore for healing. Yes, at 1 month you don't yet see full keratinization. There are still remnants of fibrin, but you don't see any wandering bone particles. And the tissue is almost mature at 2 months, and certainly after 3, 4, 5 months. And the bone at 5 months looks very well calcified. It's also seen nicely by the CBCT on these sections. And usually after 6 months, I expose the ridge for the implant. And again, I'm not interested at all to have non-integrated bone particles around the implant head actually. So I really scrape the bone with sharp Pritchard elevator. But there are almost zero non-integrated particles. And I think it's either because the kind of bone I grafted or the membrane I used here, or the combination. And this is definitely the kind of bone I want for my implants. This case 2 will be finished soon, but these kind of results definitely support the statement that socket preservation is a beautiful indication for the blue membrane. And here another case, case 14. I decided it would be better to replace the molar with 2 implants. Here the blue placed first under the lingual flap, the bone graft is placed, and the typical uncompleted coverage of the membrane. Here the membrane popped out spontaneously at 1 month. And we definitely remove it just to see that there is nice fibrin layer, which soon will be fully keratinized. Here is still case 14. At 9 months, the ridge looks perfect for placing the 2 implants in a single stage surgery. Insertion torque was more than 30 Newton centimeters. Soon we will load the implants. So before we reach the end of this webinar, I would just like to share with you a variation of the use of the blue membrane. You see, the blue is protecting the bone particles quite all right, but it's not really hermetically preventing the invasion of connective tissue cells to the socket. So I thought of placing the Jason membrane first, because the Jason is much better in adaptation to the bony walls. So this way we get the classical GBR, but since it's fast resorbing in this open healing procedure, I suggest placing the blue over the Jason to protect it and actually prevent too early resorption of the resorbable membrane. Let's see a case. In this case, case 16, the 2 molars are severely periodontally involved. We extract, place the bone. Now, first sealer is the Jason, second layer is the blue. The blue stays clean, and here I waited 5 weeks to remove it. So here again, I like to carefully make a small cut with a blade. And once this is done, I use either an explorer or this time tissue tweezers to pull out the entire membrane easily. And we see a very nice wound. No graft particles are popping out. Soft tissue layer is well organized over the wound. Typically, the flaps at this point can be deflected 3 to 4 millimeters all around. The epithelium is advancing over the organizing soft tissue, and at 9 weeks, keratinization process is advancing in full gas. And we will wait here another 2 to 4 months to place the implants. By the way, I strongly believe that building the bone first and placing the implant only after 6 to 9 months will give superior results over simultaneous bone grafting and implant placement. But this is another story for a future webinar. So, till now we have seen several ways to seal the socket. Some, like fleece or mucoderm, function as sealers just for a few days. Some, like Jason with PRF, may effectively function as a good sealer for a week or two. If we are able to completely cover the membrane with the flaps, that might be the best. But I think we all know that many times the complete flap coverage is a difficult and unpredictable task. So if we can't close the wound, we may still implement the GBR principles with a membrane that can remain in function without getting contaminated for a month and even more. And perhaps it's even better to place a resorbable membrane that adapts better to the bone under the blue membrane. Anyway, we certainly should remember that in certain situations, like in socket of type 1 with solid bony walls, the best would be to just let the socket heal by itself. So, I would like now to summarize my clinical observations with open wound approach in socket preservation in the posterior jaw. In most cases, except for the cases I used the PermaMem, there was superficial loss of grafted bone particles before complete soft tissue healing. In most cases, no matter what bone filler or sealer I used, complete soft tissue closure achieved after 8 weeks. In most cases, implant surgery was done 6 to 8 months following socket preservation. I do believe that before 6 months are over, the bone, especially the most superficial layer, is not mature enough. And then, in most cases, we saw minimal horizontal bone loss. We got the ridges between 6 to 8 millimeters in width. In all cases, there was none to 1 millimeter vertical loss of grafted bone upon scraping of the most superficial layer. Bone volume and quality achieved best with combined Jason membrane and PRF membrane, or with the PermaMem. In all cases, implant insertion torque exceeded 40 Newton centimeter, so therefore we were able to place the implants in one stage. In most cases, implants were three-dimensionally well placed, surrounded by bone of high volume and quality, as well as by keratinized tissue with aesthetic appearance. So I feel that we can confidently say that socket preservation may certainly be an open healing procedure. We don't need to close the flaps, provided we have good bone substitute and good barriers. Well, these are my observations. You probably have similar observations. I just try to crystallize my own thoughts and share them with you. So thank you for watching my cases today.